Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I am Professor Numan Nafi al-Hamdani. I will give you the fifth lecture in neonatology. That's neonatal infections, neonatal sepsis, and meningitis. The objectives is to know what are the neonatal infections and how to classify neonatal infections and what are the specific factors for neonatal infections that differ from older children and adults. What are the details of neonatal sepsis and meningitis, the types of neonatal sepsis, the principles for prevention of nosocomial infection in neonatal intensive care unit, and briefly talking about congenital infections. You have to take this quiz. You are called to attend urgent cesarean section delivery at 36 weeks gestation necessitated by maternal fever, tachycardia, fetal tachycardia, non-reassuring fetal heart racing. The prenatal course has been uneventful, but the group B streptococcal status is unknown. 6 hours before delivery, the mother began to develop fever, nausea, and vomiting, followed by onset of contraction. Due to history of anaphylaxis to penicillin, the mother received 1 dose of vancomycin during labor. Artificial rupture of membranes occur at the time of cesarean section, and it reveals light meconium-stained fluid. The infant emerged and delivered vigorous, and physical examination revealed faint erythematous rash, tachypnea, and grunting. You have to answer the following questions. What is the most likely diagnosis? What investigations he need? What initial antibiotics you will order? A second quiz is you are called by obstetric colleague about the antibiotic of choice for intrapartum prophylaxis for group B streptococcal infection. And to a patient who is 22-year-old primary mother, gravida, has presented in labor at 39 weeks gestation. She is currently afebrile with intact membrane. Her prenatal records demonstrates positive group B streptococcal screening. Results at 36 weeks gestation as positive. Upon questioning, the woman states that she has penicillin allergy that manifests just with faint rash, but no anaphylaxis, angioedema, or urticaria. Of the following, the most appropriate antibiotic for intrapartum prophylaxis for this patient? You give azithromycin, or cefazolin, or clindamycin, or erythromycin, or vancomycin. Now, what's neonatal infection? They are frequent and important cause of morbidity and mortality in neonatal period. They affect about 2% of the fetuses and 10% of the infants in the first month of life. According to the etiology, they are divided into viral, bacterial, fungal, mycoplasmal, protozoal infections. They are either called specific, there is minor and major specific bacterial infections, and non-specific called neonatal sepsis or neonatal septicemia. Bacterial neonatal infections, as we said, either non-specific called neonatal sepsis or neonatal septicemia, or specific, the major, the minor. The minor, some of the minor infections might be seen in the neonatal care unit or even in private or outpatient clinics. You could see minor specific infection like conjunctivitis or ophthalmia neonatorum. Mostly, the most dangerous one caused by gonorrhea and chlamydia, and septic spots in impetigo. They are mostly caused by staph, sometimes by streptococci. These are small lesions on the skin. And then omphalitis, that's infection of the umbilical stump, and then the oral thrush, which is commonly seen in infants who are usually bottle-fed babies. Then what are the major specific neonatal infections? We have the pneumonia, which could be congenital pneumonia from the birth, acquired from the mother, or aspiration pneumonia by blood, by meconium, by milk, which is very dangerous, especially the milk. The Staph aureus can cause serious pneumonia, which need longer treatment and associated with significant mortality. The airborne pneumonia, these are infants who went home and they acquire flu-like illness from the mother or from the sibling, and they develop subsequently pneumonia, or what's called community-acquired pneumonia. The pyogenic meningitis, we'll talk about in details. Pyelonephritis also could be dangerous and significant morbidity and mortality need to be treated. Well, osteomyelitis and septic arthritis, they are uncommon, and they are treated in the same manner because of specific anatomy of the bones in neonatal period, which differ from those in older children and adult. Epidemic diarrhea could occur as outbreak and need to be treated specifically, and tetanus neonatorum is decreasing in frequency and prevalence in Iraq, but still cases has been seen now because of the immunization. Neonatal infection. What are factors specific to neonatal infections? The first is the diverse mode of transmission of infectious agents, which could be transmitted transplacentally or during passage through birth canal or postnatally. The newborns may be less capable of responding to infection because of impaired cell-mediated immunity and because of decreased immunoglobulin, which is delivered from the mother, especially in preterm babies. Coexisting conditions often complicate the diagnosis treatment because sometimes neonatal infection can occur with other conditions. For example, respiratory distress syndrome is sometimes difficult to be differentiated. The extremely variable clinical manifestation of infectious disease of newborn, they could be subclinical, or it can be very severe or even life-threatening infection. The maternal infection is often undiagnosed during pregnancy. Some of the infections, especially in the first trimester, might be just present as flu-like illness or influenza-like illness with fever, rash, and lymphadenopathy, and might pass unnoticed, and later it proved to be one of the congenital infections which have morbidities and mortality on the neonates postnatally. The wide variety of etiological agents that infect a newborn, as we said, it could be viral, bacterial, fungal, protozoal, and other. The immature, low birth weight neonate remain in the hospital for a long period, which predispose him to acquire nosocomial infections. Now, what's neonatal infection and meningitis? There are systemic and local infections. There are certain systemic and local infections are common in neonatal period. This might predispose to neonatal sepsis and meningitis. Infection may be acquired in utero through transplacental or transcervical routes, or it is during birth or after birth postnatally. Ascending infection through the cervix with or without rupture of the amniotic fluid membrane may occur, result in amnionitis, phanecytis, which is infection of the umbilical cord, congenital pneumonia, and sepsis. What are the bacteria which are responsible for neonatal infection? They are those who are responsible for ascending infection of the fetus are common bacterial organisms of maternal genitourinary tract, like group B streptococci, E. coli, Haemophilus influenza type B, and Klebsiella. Herpes simplex virus type 1 or more common type 2 also cause ascending infection that at times may be indistinguishable from bacterial infections. Syphilis, Listeria monocytogenes are acquired transplacentally. Maternal humoral immunity may protect the fetus against some neonatal pathogens like group B streptococci and herpes simplex virus. Nonetheless, various deficiencies of the neonatal antimicrobial defense mechanism probably are more important than maternal immune status as contributing factor for neonatal infection, especially in low birth weight infants. The incidence of sepsis is approximately 1 to each 1,500 a term baby, but 1 to 250 in preterm baby. The six-fold higher rate of sepsis in preterm compared with a term infant may be related to the more immature immunological system of preterm infant and their prolonged period of hospitalization, which increased risk of nosocomial acquired infectious disease. The preterm infants before 32 weeks of gestation have not received the full complement of maternal antibodies, especially the IgG, which cross the placenta by active transport, predominantly in the latter half of the third trimester. In addition, although low birth weight infants may generate IgM antibodies, their own IgG response to infection is reduced. These infants have also deficiencies of alternate complement pathway, and to smaller degree the classic complement activation pathway, which result in diminished complement mediated opsonization. Newborn infants also show deficit in phagocytic migration to the site of infection, like to the lung, to the bone marrow, and in the bone marrow the reserve pool of leukocyte. In addition, in the presence of suboptimal activation of the complement, neonatal neutrophils ingest and kill bacteria less effectively than adult neutrophils do. Neutrophils from sick infants seem to have an even greater deficit in bacterial killing capacity compared with phagocytic cells from normal neonates. Defense mechanisms against viral pathogens also may be deficient in a newborn. Neonatal antibody-dependent cell-mediated immunity by the natural killer lymphocytes are also deficient in the absence of maternal antibodies, and in the presence of reduced interferon production. Reduced antibody level occur in premature infants and infants born during primary viral infection of the mother, such as with enterovirus, herpes simplex virus type 2, or CMV. In addition, antibody-independent cytotoxicity may be reduced in lymphocytes of newborn. Now, what's the incidence and the organisms responsible for sepsis and meningitis in neonates? Bacterial sepsis and meningitis are often linked closely in neonates. Despite this association, the incidence of meningitis relative to neonatal sepsis has been on a steady decline. The incidence of meningitis approximately 1 in 20 cases of sepsis. The causative organisms isolated most frequently are the same as for neonatal sepsis. That's the group Streptococcus, E. coli, and Listeria monocytogenes. Gram-negative organisms such as Klebsiella serrata maricensis are more common in less developed countries. Coagulase-negative staphylococci need to be considered in a very low birth weight infants. What are these factors? Male infants seem to be more susceptible to neonatal infection than female infants. Severely premature infants are even greater risk secondary to less effective defense mechanism and deficient transfer of antibodies from the mother to the fetus, which usually occur after 32 weeks gestation. Neonates in the NICU live in a hostile environment with exposure to endotracheal tubes, central arterial and venous catheters, and the blood draws, all predisposing to bacteremia and meningitis. Genetic factors has been implicated in the ability of bacteria to cross the blood-brain barrier. This penetration has been noted for group B Streptococcus, E. coli, Listeria, and Citrobacter, and Streptococcus pneumoniae. Now, how we classify or divide neonatal sepsis? Neonatal sepsis present during 3 periods of immediate postnatal life. We have the early, from birth to 7 days, late onset sepsis from 8 to 28 days, and we have the nosocomial acquired sepsis, that's from 8 days to discharge, or if the patient is delivered in the same hospital, then it will be from birth. From the up to date, we have a common bacterial agent causing neonatal sepsis in a term infant, and these are the organisms' frequency of the isolation in early onset and late onset. We could see that group B Streptococcus and E. coli occur both in early onset and late onset sepsis, while the others like Klebsiella, Enterobacter, Listeria monocytogenes, other enteric gram-negative and non-enteric gram-negatives, and viridans, Streptococcus viridans, all occur equally in early and late onset sepsis, while organisms like Streptobacter, Salmonella, coagulase-negative staphylococci, and enterococci tend to occur only as late onset sepsis. And these are the suggested antimicrobial regimen in the management of neonatal sepsis in term and late preterm infants. You could see we are talking now in this table about empiric treatment, the empiric treatment of different types of neonatal sepsis and meningitis. The empiric treatment, if the patient come with early onset sepsis less than 7 days, then we start with ampicillin and gentamicin. Late onset, more than 7 days, admitted from the community, that's community acquired, then also ampicillin and gentamicin. Late onset, hospitalized from birth, this is nosocomial infections, then gentamicin and vancomycin. Then there are special circumstances like suspected meningitis. This is all our empirical treatment. Suspected meningitis, early onset, ampicillin and gentamicin. Suspected meningitis, late onset and admitted from the community, ampicillin and gentamicin and cefotaxime. Suspected meningitis, late onset, hospitalized since birth, these are nosocomial. We start with gentamicin, vancomycin and cefotaxime. Suspected pneumonia, we start with ampicillin and gentamicin. Alternatively, we can give ampicillin and cefotaxime, or vancomycin and cefotaxime, or vancomycin and gentamicin. Suspected infection of the soft tissue, skin, joint, bones, where Staphylococcus aureus is likely pathogen, we should start with vancomycin alone or vancomycin plus Nafi, which is anti-staph. Suspected intravascular catheter-related infections, especially if you are giving central line, then vancomycin and gentamicin. Suspected infection due to organisms found in the GIT, these are usually anaerobic organisms, we should either start ampicillin, gentamicin, and metronidazole, or piperacillin, tazobactam, and gentamicin. These are the suggested antimicrobial agents in the management of neonatal sepsis in term and late preterm according to the culture. Once the culture appear, blood culture, CSF culture, then we can give antibiotic according to specific pathogen specific antibiotic. For example, group B streptococci is usually sensitive to penicillin G. E. coli, there is ampicillin sensitive, we give ampicillin and cefotaxime. While if E. coli resistant to ampicillin, then we give meropenem. There are multi-drug resistant gram-negative bacilli, then we give meronym, Listeria monocytogenes, ampicillin and gentamicin, and you have to take in consideration that the only ampicillin is sensitive. Listeria is usually sensitive to ampicillin, and you should not give any other drug other than ampicillin in management of Listeria monocytogenes. So we give ampicillin and gentamicin. Methicillin susceptible Staph aureus, Nafi or cefazolin. Cefazolin is first generation cephalosporin. Methicillin resistant Staph aureus, vancomycin. Coagulase negative Staphylococci, vancomycin. Now, early onset sepsis often begin in utero and usually is a result of infection caused by bacteria in the mother's genitourinary tract. Organisms related to this sepsis include group B streptococci, E. coli, Klebsiella, Listeria monocytogenes, and non-typable Haemophilus influenzae. Most infected infants are premature and show non-specific cardiorespiratory signs such as grunting, tachypnea, and cyanosis at birth. Risk factors for early onset sepsis, which occur from birth to 7th day: vaginal colonization of group B streptococci, prolonged rupture of membrane more than 24 hours, and some consider more than 18 hours, immunitis, maternal fever or leukocytosis, fetal tachycardia, and preterm birth. There is also another unexplained additional risk factors for neonatal sepsis. These are the African American race and male sex. Now, what clinical presentation? Early onset sepsis is a overwhelming multi-organ system disease, frequently manifest. These are late signs: respiratory failure, shock, meningitis in 30%, disseminated intravascular coagulation, acute tubular necrosis, and symmetrical peripheral gangrene. But usually they present early as grunting, poor feeding, pallor, apnea, lethargy, hypothermia, or abnormal cry, and these are early manifestations are non-specific. Profound neutropenia, hypoxia, hypotension may be refractory to treatment with a broad-spectrum antibiotic and the use of mechanical ventilation and vasopressors such as dopamine and dobutamine. In the initial stages of early onset sepsis in the preterm, it's often difficult to differentiate between sepsis and respiratory distress syndrome. Because of this difficulty, premature infants usually receive broad-spectrum antibiotic even if they have just RDS. The clinical manifestation of sepsis are difficult to differentiate from manifestation of meningitis in neonates. So what investigation we do to evaluate patients suspected to have early onset sepsis? We should do blood culture and sensitivity, aerobic and aerobic, and from two sides. Lumbar puncture, CSF culture, gram stain. For the CSF, we do general examination, gram stain, and general examination including count, protein, and glucose, and CSF culture. Normal newborn, generally they have elevated CSF protein up to 100 or even 150 milligram per deciliter, and may have 25 to 30 per cubic millimeter white blood cell count. The mean is 9 per cubic millimeter, which are 75% lymphocyte in the absence of infection. These are normal. Some infants with neonatal meningitis caused by group B streptococci do not have elevated CSF leukocyte count, but are seen to have microorganisms in the CSF when we did gram stain and culture. In addition to culture, determination of bacterial antigen in a sample of blood, CSF, and urine may be considered. Cases of neonatal meningitis, the ratio of CSF glucose to blood glucose usually is less than 50%. So when we do lumbar puncture, we should do with lumbar puncture blood sugar to compare with the CSF sugar. Early onset sepsis also we can do PCR test to identify viral infection. We can do C-reactive protein test, and we do it serially, probably 12-hourly, to identify neutropenia and increased number of immature neutrophils and thrombocytopenia. CRP level often elevated in neonatal patients with bacterial sepsis. Chest X-ray to determine the presence of pneumonia. And pneumonia in low birth weight infants may be the result of equation from the maternal genitourinary tract, like Mycoplasma pneumoniae, Uriplasma urinalyticum, Mycoplasma hominis. Arterial blood gas to detect hypoxemia and metabolic acidosis that may be caused by hypoxia, shock, or both of them. Blood pressure, urine output, peripheral perfusion to determine the need to treat specific shock with fluids and vasopressor agents. Treatment for sepsis and meningitis. The mainstay of treatment for sepsis and meningitis is antibiotic therapy. Antibiotics are used to suppress bacterial growth, allowing the infant's defense mechanism time to respond. Supportive measures are very important, including assisted ventilation, cardiovascular support. They are equally important in the management of neonatal sepsis. Combination specific, that's by antibiotic, combination of ampicillin and aminoglycoside. Usually gentamicin for 10 to 14 days is effective treatment against most organisms responsible for early onset sepsis. The combination of ampicillin and cefotaxime also is proposed as alternative method of treatment. If meningitis is present, the treatment should be extended 21 days or 14 days after negative result from CSF culture. Persistent deposit results from CSF culture are common with neonatal meningitis caused by gram-negative organisms, even with appropriate antibiotic treatment, and may be present for 2 to 3 days after antibiotic therapy completion. Treatment for sepsis and meningitis. If gram-negative meningitis is present, some authorities continue to treat with effective penicillin derivative combined with aminoglycoside, whereas most change to third-generation cephalosporin like cefotaxime. High-dose penicillin is appropriate for group B streptococcal meningitis. Inhaled nitric oxide, ECMO, or both may improve the outcome of sepsis-related pulmonary hypertension, and both of them are not available in Iraq. Intratracheal surfactant may reverse respiratory therapy, and we mentioned that surfactants is used in respiratory distress syndrome, but other uses in developed countries, because they have a good money, they can use it for pneumonia, for other like pulmonary hemorrhage. Intrapartum penicillin empirical prophylaxis for groups B streptococcal nice mother or mother with risk factors has reduced the rate of early onset infection. Late onset sepsis, that's the sepsis, neonatal sepsis occurring from 8 days to 28 days. It usually occurs in a healthy full-term infant who was discharged in a good health from the normal newborn nursery. Clinical manifestations may include lethargy, poor feeding, hypotonia, apathy, seizure, bulging, fontanelle, fever, and direct hyperbilirubinemia. In addition to bacteremia, hematogenous seeding may result in focal infections like meningitis, and you have to be careful. Early onset sepsis associated with 30% meningitis, while in late onset sepsis, 75% of them they have meningitis. Osteomyelitis also you have to take consideration in late onset sepsis and arthritis, and urinary tract infection as pyelonephritis. The evaluation of infants with late onset sepsis is similar to that for infants with early onset sepsis, with specific attention to careful physical examination of the bones to exclude osteomyelitis and septic arthritis, laboratory examination to do general urine and urine culture, and the urine sample should be taken from suprapubic aspiration or urethral catheter. Late onset sepsis may be caused by the same pathogen as early onset sepsis, but infant exhibiting sepsis late in the neonatal period also have infection caused by pathogen found in older infants like Haemophilus influenzae, Streptococcus pneumoniae, Neisseria meningitis. Also, we should take in consideration viral agents like herpes simplex virus, CMV, or enteroviruses, which could also manifest as late onset sepsis. Because of the increased rate of resistance to Haemophilus influenzae and pneumococci to ampicillin, some centers begin treatment with ampicillin and third-generation cephalosporin and vancomycin if meningitis is present when sepsis occurs in the last week of the first month of life. The treatment of late onset sepsis and meningitis is the same as that for early onset sepsis. The other type of neonatal sepsis is called nosocomial acquired sepsis. That's occurring either if the baby delivered in the same hospital from birth, or if he was referred from other hospital from day 8 to discharge. What are the risk factors and clinical features that occur predominantly premature infants in the NICU? Many of these infants have been colonized with multi-drug resistant bacteria resistant to treatment, and they are usually present in the NICU. The risk of such serious bacterial infections is increased by frequent treatment with broad-spectrum antibiotic for sepsis, by presence of central venous enduring catheter, frequent use of endotracheal tubes, and umbilical venous and arterial catheterization, and electronic monitoring devices. Epidemics of bacterial or viral sepsis and diarrhea and others are common in the NICU and in the nursery for well baby infants. How we treat nosocomial infections? The treatment of nosocomial infection depends on the indigenous microbiologic flora of the particular hospital and the antibiotic sensitivities. Staph aureus, occasionally methicillin resistant, Staph epidermidis, like methicillin resistant and gram-negative pathogens are common nosocomial bacterial agents in many nurseries. They require combination of vancomycin or oxacillin nafcillin. These are anti-staph, not available in Iraq. Some use ampicillin with aminoglycoside, gentamicin or topramycin is appropriate. The dose and interval for administering all aminoglycosides such as gentamicin vary with postnatal age and birth weight. Treatment with aminoglycoside for more than 3 days necessitates monitoring of the serum peak and trough concentration of gentamicin to optimize treatment to avoid ototoxicity and nephrotoxicity of aminoglycoside. Persistent signs of infection despite antibacterial treatment suggest candida or viral infection which may require treatment. What are the principles for the prevention of nosocomial infection in the NICU? First, we have to observe recommendation for universal precaution with all patient contact using gloves, gowns, mask, and isolation. The nursery design is also important, appropriate nursing patient ratio. Avoid overcrowding of the patients and excessive workload of the nurseries, like nurses and doctors. Readily accessible sinks and availability of antiseptic solutions, soap and paper towels, disposable paper towels. The hand washing is very important. Improve hand washing compliance. Wash hand before and after each patient encounter. appropriate use of soap, alcohol-based preparation or antiseptic solution, alcohol-based antiseptic solution near each patient. Provide emollients for nursery staff, education and feedback for nursery staff about hand washing and other parts of prevention of infection. You have to minimize the risk of central venous catheter contamination, maximize sterile burial precaution during CVC insertion, local antiseptic chlorhexidine gluconate, minimize repeated entry into the line for laboratory test, aseptic technique when entering the line, minimize CVC days, sterile preparation of all fluids to be administered through CVC, meticulous skincare, encourage early and appropriate advancement of enteral feeding, especially breastfeeding, education and feedback for the nursery personnel, and continuous monitoring and surveillance of nosocomial infection rate in the NICU, the rate, the type of the organism, and the sensitivity of antibiotic to each organism. We just talk in summary about congenital infections because the details are given already by Assistant Professor Dr. Hassanin Ghali. So infection acquired transplacental during gestation is called congenital infection. Numerous pathogens that produce mild or subclinical disease in older infants and children can cause severe disease in neonates who acquire such infections prenatally or perinatally. Sepsis, meningitis, pneumonia, and other infections caused by numerous prenatally acquired pathogens are the cause of significant neonatal morbidities and even mortalities. Congenital infections include well-known group of fungal, bacterial, and viral infections like Toxoplasma, Rubella, CMV, herpes simplex, varicella, zoster virus, congenital syphilis, parvovirus, human immunodeficiency virus, hepatitis B, Neisseria, gonorrhea, chlamydia, and mycoplasma, Mycobacterium tuberculosis. And this is diagrams of how congenital infection can present: congenital, in utero infections, or perinatal infection, or postnatal infection. So congenital infections, many of the clinical manifestations of congenital infections are similar, including intrauterine growth restriction, non-immune hydrops, anemia, thrombocytopenia, jaundice, hepatosplenomegaly, chorioretinitis, and congenital malformations. How we evaluate such patients who are thought to have congenital infections? First, attempt to isolate the organism by culture, like Rubella, CMV, herpes simplex, gonorrhea, and Mycobacterium tuberculosis. Second, to identify the antigen of the pathogen for hepatitis B, chlamydia, trachomatis, to identify the pathogen's genome with PCR, to identify specific fetal production of antibiotics, IgM, or increasing titer of IgG for Toxoplasma, syphilis, parvovirus, HIV, or Borrelia. Treatment is not always available or specific or effective. Nonetheless, some encouraging results have been reported for preventing the disease and for specifically treating the infant when the correct diagnosis is made. And this is all about neonatal infections. And thank you very much.